Welcome back. We're going to start our Patients and Advocacy and Supportive Care section, co-chaired by Dr. Chiara Bracconi and Dr. Rocio Matthias, who you've already seen chair previously. Just before I hand over to them, I wanted to clarify at the request of 2 or 3 people who have asked me over the last 24 hours around the voting process. So we are not in the process of identifying one biggest priority or the top 2. We're not ranking the priorities at the moment. The main questions are really, is this priority good enough to reach the level of a research priority for the field of cholangiocarcinoma? So each and every question could reach the threshold, it could be good enough, but we do want to find out if there are some that don't reach that mark, and obviously then they would not be a priority. But just for the patients and caregivers, we are not asking you, like The Voice, to wait to see which is the best one of these, and that's the one that I will vote for. Please consider each one on its own merit and think, is this good enough to be a research priority? And with that, I'll hand over to our co-chairs.
Well, we start this new important session. We have Stacy, she doesn't need introduction. And we also have Helen Mortimer, and she's the CEO of AMMF, the UK's only cholangiocarcinoma charity. She's dedicated to raising awareness, providing information, and supporting research for cholangiocarcinoma. And they are going to introduce this session.
Thank you. Okay, here we are. I just want to introduce our working group and thank them for their time and all the effort that they put into helping us put forward these recommendations. Our session is going to look a little bit different, and so we hope that you'll work with us and we can get to consensus on some of the things that we want to get started. Okay. First, I want to say, you can see that these are global leaders of nonprofit organizations for cholangiocarcinoma. We also have a nurse, we have a couple of researchers, and I put one as special counsel on the side because he was very helpful to us, so thank you. These were just some of the research questions. You know that there was a survey done for all of the working groups. And I want you just to consider this list. There is nothing on this list that is not important to patients and caregivers. This was the hard thing, is we're trying to decide, one, what we could work on together as a global community, and two, what were the things that we were hearing in our communities all the time. So that's the way that we came to the priorities. And again, you have endpoints and trials, which is being dealt with another one of the groups, exercise, financial toxicity, all of these things are important. This is not to say that the 4 recommendations that we chose were the most important, but these were things, again, that we felt like we could do together as a global community. So these are the 4 priorities, and then the recommendations will show you. Helen and I are gonna trade off with these, but the first one was patient and caregiver education. The second, nutritional support. The third, complementary therapies, and the 4th, clinical nurse specialist. I'm going to go first with patient and caregiver education. So I just want to tell you first, when we start, what we see as advocacy groups globally, what the patients are telling us. And the first thing is that the patients are often not provided with sufficient information to empower them to take the necessary actions when issues arise at home. So this could be identifying when they need to go to the ER. When they're caring for drains and stents at home, they need more information to do that. And when they have a heightened feeling of unwellness, so maybe they get a fever or jaundice, increased fatigue or itching, and they're just not sure if that's something that they need to address or not. So we looked at a lot of publications, and in this section, I'm going to talk about some things that we found that were notable, but we did not put in the recommendations, because I want you to know as patients and caregivers that we looked at a lot of things. So under patient and caregiver education, there was an article on education to reduce risk and increase screening. This was a small study done in Thailand. It showed the effectiveness of educational intervention for risk factors and screening. They did a pre-survey and a post-survey and showed that educational interventions can effectively promote preventive behavior against cholangiocarcinoma. Another finding that was notable that did not get into the recommendations was peer support interventions. This was a summary of 23 studies. None were cholangiocarcinoma specific, but notable is that the most impactful intervention that they found in this group of 23 studies was online group discussions. So these support groups that all of the organizations are doing are very important. Another notable but not in the recommendations was a caregiver education programs. This was a summary of 119 publications about caregiver education, none focused on cholangiocarcinoma. And the determination of that summary was that there was a lack of programs that address the diverse needs of caregivers, including practical skills to help their patients at home. Again, another notable but not in the recommendations was care inequality between rare and common cancer patients. And this explored and compared the experiences, needs, and quality of life of patients with rare cancers and common cancers throughout their disease trajectories. So they found three significant things. One, this is a solitary experience. Well, three things that differed from getting a common cancer diagnosis. You're having a solitary experience, you have a lack of information and support and feelings of isolation. I think all the patients in this room understand that. Low disease recognition, and that means that when you tell someone you have cholangiocarcinoma and they say, I've never heard of that before. Another isolating factor, and a lack of empowerment to manage their cancer journey. They don't have enough information to manage things the way that they do in common cancers. So again, notable but not in the recommendations. Another notable but not in the recommendations was a publication called Clinical and Socioeconomic Determinants of Survival in BTC. I think everyone is aware of this. Worse survival outcomes were observed in lower income countries. Higher income and education levels are associated with higher 5-year overall survival among gallbladder and biliary malignancies. The US and the UK also see these disparities. I'm sure all countries see this as well. Another notable finding, but not in the recommendations, was informational needs and outreach preferences of patients. This was done in 2024. It's a cross-sectional survey study which examined the informational needs and outreach preferences of patients with hepatobiliary malignancies, which include cancers of the liver, bile ducts, and gallbladder. So the key findings were that 56% of the patients needed more information. They were not getting enough information. The preferred topics that they needed information about were treatment options, symptom management, and nutrition. The engagement preferences, 70% of the patients preferred online engagement. Screening awareness, 82% were interested in learning more. We'd all love to see screening, but it's not a very good option right now for us. And multidisciplinary care communication. They need more information and better information about the recommendations from their tumor board. So again, okay. So why do we need to educate patients better? We want to help them to seek upfront medical support before infection or sepsis, before hospitalization, before they have a loss of fitness, and then that could delay active cancer therapies. And what we are hoping for is a better quality of life and improved outcomes, and including survival. So we made two recommendations, and we're making two recommendations. You may not look at these as research priorities, but just wanted to, I'll explain. So one is fund a global patient education program to reduce cancer-related complications and develop a framework for managing urgent conditions like colitis. This would be the development of a pilot focused on cholangitis. We want to start there, and then the second recommendation would be to develop a framework to educate patients on managing other related urgent conditions like biliary obstruction and drain malfunctions. I think the first needs to be a pilot because we need to figure out the best way to do that. There are lots of publications that have done some of this work, so we would take the information from those, figure out how we could distribute that information, and then we would develop the framework. So, does anyone from our group want to have anything to add before we go to the first recommendation? No? Okay. I'm getting no's over there. Okay, so the first recommendation is fund a global patient education program to reduce cancer-related complications and develop a framework for managing urgent conditions like colitis. And remember, these are to help patients and caregivers when they are at home, know when they are in an urgent situation and when they are not, and know how to handle things best.
Can we have the lights up, please, and open for discussion? Or comments? Can we stop the vote, please?
Louis?
Thanks. I'd just like to commend your group on the work that you've done, and particularly commend the third word in the global, because I think, as you've mentioned, there's huge needs globally in this space, and I think it's really important for us as a foundation to take the lead here and see if we can't help mobilize assistance for people in particularly some of the low and middle income countries. Thanks.
Thank you. This is Louis Roberts from Mayo Clinic. And our thought is that this would be, that we would first have to decide how we would do this, and then translations, all those kinds of things, so that these could be white labeled and given to foundations all over the world to help their patients. I think we
Any
can
other
vote.
questions?
Yeah.
Can I just ask you
Yeah.
about a comment? So following Louis' comment, obviously the framework for managing these conditions is going to be different from one country to another. So do you have a plan to engage with different countries and try to make it applicable, or just more kind of educational, more vague, ideas?
Do you mean different kinds of cholangitis? Do you
No,
mean different?
I mean, the way the cholangitis may be
the way that it
managed and implemented, the pathway
Okay.
for managing it would be different. I'm assuming probably in Italy, UK, United States, Africa. So how do you envisage to really, overcome this challenge? To probably interact and try to engage with different countries to have a better idea of how, things will happen in the territory and give the proper advice?
That's a very good question, and really not one that we discussed in our group. I think our thought was to start here with a pilot, and then it'll have to be country specific for sure. We wouldn't send out a proposal. I think we would just have to work together with all the other organizations. Helen, I don't know if you have any thoughts, or Juan.
I was just going to suggest from maybe the table from the different countries, how would you see a single recommendation versus building this gradually into global but different recommendations or linked recommendations? Maybe if you can comment from your various countries. There should be a microphone on that.
Can I come in just while they're doing that? I think our thoughts were really to come up with what would be an optimum pathway. Sorry, thank you. Sorry, I think our thoughts originally would be to come up with an optimum pathway, to come up with some sort of, consensus as what would be the right way to look after these patients. And then, of course, it would have to be adapted country by country, healthcare system by healthcare system. I think that's basically what we were thinking.
Priyanka?
Yeah, so I completely agree with Helen. I feel that, we can just put up like a basic resource within our work group to understand what are the major priorities we have to deal with. And of course, the healthcare priorities in every other country is different, how it is in India versus how it is in US. So I feel that, we can independently run our own different pilot projects in our own different countries and see and regroup together to understand the commonalities between them, and also discuss, how they are different, and try to establish some kind of framework where we are able to engage together in these aspects.
Thank you, Katie, and then microphone one.
I think Some of this also harkens back to the discussion yesterday about management of biliary obstruction, which is so site and region and patient and anatomy specific and institutional expertise specific that it's perhaps not the best investment of resources to try to micromanage across a global scale. On the other hand, there are some general points that I think are true, whether you're in Africa or San Francisco or Salt Lake City, which is that if you have a drain or stent in place and you get a fever and shaking chills, you don't wait at home for 48 hours, you seek care and you need antibiotics. That is a simple truth that could be put into different languages. Of really simple points on a one-pager like that, I think would be useful on a global scale and true on a global scale. I don't think it would be valuable to spend a lot. It would be an exercise of many, many months and years and lots of people to try to, and chasing a moving target too, as technologies and treatments change, to try to prescribe exact management on the medical side of things. But I think telling patients at home, if you have a stent in place and you have fevers and chills, you go to the ER, you call your doctor, that would be helpful. Because not all patients hear that. I have patients who have stents who get a fever and chills, and they haven't been told, don't wait for 48 hours until Monday morning.
Yes, thank you, Katie. Back up to one, and then we'll go to Dr. Iyer. Back to one. Yep.
Caitlin Conboy from Mayo Clinic. Part of what I was going to say is exactly the same as you, Katie. So I want to focus on the same point. The goal of this is the patient education component, not educating providers on how to manage it, is how I see it. I imagine some of those small videos, like what you did for educating patients that they need NGS testing to identify targetable mutations, you know, that kind of video that can be translated, just as Katie was saying. I think it has a lot of value and doesn't have to be a Herculean project.
Yeah. Dr. Iyer?
Renuka Iyer. The biliary emergency card, when it came out, you had done an initial project, show me your card. Something along those lines might be of value, you know, to sort of see whether that would be well received by the audience. The other thing that Juan and, you know, we all had worked and we're still trying to get it out as a publication might be important for providers because the nurses and the stent endoscopy suite staff, if they are aware that only 1 in 10 times do these patients, at least from that database, end up in the same place where they actually got their stent or, you know, PTC placed, if that awareness is made more, you know, kind of universally known to the providers, that you need to know that 1 out of 10 times they're going to end up with you. Most of the time these problems happen and they go somewhere else. This is why you need to also, that education might also kind of land and get us closer to where you want to go. And then the last thing, one of the issues that is maybe for a different group, when the Nursing Advisory Board had tried to look at, you know, the flush or not to flush question and polling all the NCCN cancer centers and just trying to see, like, even just within those 33 centers, what is being told to the patient who's going home with the PTC, whether it has a bag, it doesn't have a bag, it's draining inside, outside. And they could not come up with a consensus from even just the NCCN centers, sort of to make the point that getting a consensus, you know, just echoing what others have said, getting everyone to agree all over the world might be hard. We can't even get the NCCN centers to sort of agree, and the hope is not to change their practice. The hope is to get the person in front of a provider who can address that issue in whatever best practice. Thank you.
Yes, thank you. Go ahead, Juan.
So I think in the discussions, which I was privy to be in the group, and thank you for including me, this was, remember, focused on patient education. And what we mean by education is very, very wide. It might just be a black and white sheet that people have as they're leaving the hospital together with lots of other information, and we think the patient's been educated through to something much more rigorous and formal. And I really liked, I've mentioned this before in the group, and I sometimes can't see it translating into reality, but the team in Thailand published a paper on educating patients in a proper educational manner. So they gave them the information, they then tested them, you know, to see whether, check the understanding. And patients who went through that process and had their understanding checked were much more likely then to have an improved outcome. So something along here was thinking more along the lines of patients who have stents or at risk of biliary obstruction, it's not just educating them, but testing the understanding. Do they understand what they've heard? Do they understand the urgency, to Katie's point, not waiting until the next clinic or at the end of the weekend, that this is something urgent that needs to be done? So the research question was more about formally evaluating an education and testing rather than what we think is education, just giving out a sheet of paper and hoping for the best.
Are we ready to vote? Okay. You can start the timer. Woohoo. Helen? Good. Yeah.
Well, I'm going to talk a little bit about the discussions we had around nutrition. And thank you very much. And just again to begin with, what do we as advocacy groups see and what do our patients tell us? Well, we know that there are many dietary and nutrition problems for patients with cholangiocarcinoma, and I'm going to run through a few of them. A lot of them are very concerned that they need to manage weight loss, which is very difficult for them when they see themselves losing weight. It's very difficult to maintain a healthy diet when you don't want to eat, when your mouth is sore, when your taste is changed, and so on. And patients need to know what can be done with diet to manage the side effects of cancer therapies, and they need a lot of help in that area. And there's also a couple of very poorly understood conditions that are important in the area of cholangiocarcinoma. And I'm just going to sort of run through those a little bit because they did come up actually yesterday, I noticed in one of the discussions. So I just want to explain them a little bit more fully because they really are not understood. And one is BAM, which is bile acid malabsorption. Now, this is a condition where the body doesn't properly absorb bile acids, which are essential for digesting fats. And this can lead to a number of distressing symptoms and can actually leave people housebound because they absolutely have to be close to a toilet, and that's really difficult. So a resection, gallbladder removal, damage to the small intestine due to disease, surgery, or radiation treatment can all lead to this condition, BAM. But with medication and dietary advice, it can be helped. And the other condition is SIBO, which is small intestinal bacterial overgrowth. And in this condition, there's an abnormal increase in bacteria in the small intestine, again, often leading to a number of really distressing digestive issues, again, such as diarrhea, bloating, urgency, malabsorption, etc. And again, some of the causes of this include a weakened immune system, intestinal surgery, and repeated antibiotic use. So antibiotics disrupt the gut microbiome and can allow this bacterial overgrowth. And again, correcting nutritional deficiencies is a crucial part of treating SIBO. So when someone receives a diagnosis of cholangiocarcinoma, it seems as if everything in life spirals out of control. Decisions seem to be out of your hands. Knowing how nutrition can help is important, not only with the various digestive problems and side effects of treatment, but also because it can be one way of giving a little of that control back. However, this is dependent on receiving informed advice that's right for you, the individual. But the dietary and nutrition advice and care cholangiocarcinoma patients tell us that they've received is far from universally good, and in some cases, almost non-existent. So as a group, we set out to explore what research currently exists into the dietary and nutritional needs, specifically of those with cholangiocarcinoma. And in particular, we looked for research in the following areas: before and after surgery, and after other treatments such as chemotherapy. So the information we found around surgery focused on nutritional status pre and post-surgery to investigate outcomes, all very necessary, of course, but there was little or no information on the advice and care that should be given to the patient. So when thinking about surgery for cholangiocarcinoma and the major changes this can mean to the digestive system, many people can no longer cope with fatty foods as they once might have done, and in some cases they need enzyme replacements. Well, people need specific dietary advice to enable them to manage their changed digestion, to get back to good health, and to maintain a good nutrition status. As we know, those diagnosed with cholangiocarcinoma who are undergoing chemotherapy or other therapies, or who are stented, may have a number of difficult side effects to deal with. And whilst we know there are various changes to diet that are advised to cope with these, we didn't find any specific research in this area. And also, people undergoing chemotherapy or who are stented may experience repeated infections, often requiring repeated treatment with antibiotics. And this can then affect the balance of the gut flora, the microbiome, leading to a number of digestive problems, including that potential overgrowth of certain bacteria. Correcting nutritional deficiencies is a crucial part of treating these problems. But in the published work we looked at, we didn't find any studies on the role of nutrition in palliative care for cholangiocarcinoma, and we felt this was an important gap in the literature. So, cholangiocarcinoma patients certainly need better advice on nutrition and coping with digestive difficulties after a resection or palliatively than seems to be currently available. So we considered that the next steps should be to undertake studies specific to nutrition in those with cholangiocarcinoma. And these are urgently needed because of the effects on the biliary tract and digestion caused by the cancer and all the treatments. And that specific topics merit that investigation include a low-fat diet, fat-soluble vitamin supplementation, and probiotics after repeated antibiotic use. And this is our recommendation, that nutritional research in patients with early and advanced cholangiocarcinoma is a priority, with a specific focus on the long-term nutritional needs and dietary recommendations.
Thank you. Can we have the lights on so we can open the discussion? Any comments? Can I remind you that you introduce yourself and then you make your comment?
Sure.
Thank you.
My name's Bob Etchery, and I'm a caregiver for my wife, who was diagnosed late October last year. And one of the things that we noticed as, normal people, is you go on the internet and there's tons of things you're supposed to eat, you're not supposed to eat. This kills tumors, this grows tumors, avoid sugar. When we talked to the dietitians, their main concern was don't lose weight. And I think it's frustrating for patients and caregivers when you have all this information. A lot of it is false. Maybe, you know, if there could be something that says, don't eat this, eat this. You know, this sugar causes cancer to grow. On the internet, it does. In the hospital, when you talk to people, it doesn't. So anyway, I think that would be a lot of help for us non-technical people. Thanks.
Can I come back on that? Is that okay? I think that's a really valuable point. I don't think there's any proof that any food is going to cure cancer, but I think there certainly is a need for more specific dietary advice for cholangiocarcinoma patients. I mean, there's a lot of advice about helping to gain weight, you know, eat cream cakes, take more butter, have full fat milk. Well, that's going to be agony for people with real digestive problems after cholangiosurgery. So yeah, we need specific advice, not general advice.
Thank you. Angela first, and then microphone 1.
Thank you. So it's Angela Lamarca from Madrid, Spain. And I think it would be really important, Helen, regarding the nutritional research. Is this for diagnosis of the nutritional needs? Is this for management of those nutritional needs? And then that is from a research point of view, but I fully agree with the comment about the current recommendations, you know, having a source where our patients can really go and don't read any crazy ideas that are there in the internet. So maybe separate research from those recommendations.
Mm-hmm.
Thank you. Microphone 1.
Yep, my name is Matt Reedy. I'm a patient, 12-year survivor, and I have a recommendation, I guess, on the wording. The wording as it is now, it's limited to patients with early and advanced cholangiocarcinoma, but it also applies to survivors. You know, I've had a resection. I've got issues with SIBO. I've got issues with pancreatic digestive enzyme insufficiency. I've had recurrent cholangitis as a result of strictures in my reconstructed bile duct. You know, I take heavy-duty antibiotics daily as a prophylactic to prevent the cholangitis. So I deal with all these things on a daily basis, and I'm a survivor. I'm grateful for every day, but it really does affect quality of life, not only for patients but for survivors. So not limiting this to people with active disease, but including, you know, I get the feeling that things have progressed over time so much that as there are more survivors, you know, we're thankful to get an opportunity to have surgery, but there's not a lot of information or research about the long-term effects of the surgery. You know, we're thankful to be cured in some cases, but there are a lot of longer-term survivorship things that ultimately, you know, if the foundation can help in that aspect too. It's certainly not a priority, but it's another aspect of.
No, thank you. I mean, I think it is a priority, and probably a rewarding of the recommendation, including survivors, is definitely fair. Yes, Katie.
Microphone 3 first.
Hi, Donna Martin, and I'm from New York, and I just want to say that as a patient, I've been going through this since December of 22, and I have the FGFR gene. In the beginning, I wasn't really given a lot of information about nutrition. I had to look a lot of things up myself, but it wasn't until I started going to infusion that one of the oncology nutritionalists came in and sat down with me, and I made an appointment with her, and we went over all of my current diagnosis and prescribed a you know, a way for me to going about my diet. You could tell I haven't really lost any weight, but I've been pretty stable, and at home I eat clean, I garden, I do everything I can. I can eat vegan, vegetarian, and a carnivore. So I mix them along with the low phosphate diet that I have to be on because of hyperphosphatemia. So, which I developed taking the futibatinib. So I would like to say to all the patients to ask your doctor about seeing an oncologist nutritionalist because they're so helpful in guiding you into where you need to go. So I just wanted to share that with everybody.
Thank you. So Katie and then Myra.
Thanks so much. I think this is a hugely topical and important topic. I would perhaps suggest rather than, I think this is also though an area where the rarity and heterogeneity of cholangiocarcinoma becomes a challenge for primary research. And while I agree that we need guidelines and recommendations for our patients that are tailored to their cholangiocarcinoma diagnosis, I worry that embarking on primary research in cholangiocarcinoma will be an enormous endeavor, and I think maybe too great for us to surmount on an individual disease level. Instead, I wonder if it might make the most impact to focus on the specific types of nutritional conditions that cholangiocarcinoma patients face, such as post-Whipple, such as SIBO, as Matt alluded to, such as gallbladder issues, and then align forces with other groups such as pancreas surgical societies who have a lot of patients with particular similar types of surgery for any indication, and then develop a clearinghouse of recommendations and websites for those individual conditions that are vetted resources for patients so people don't go down the rabbit hole of the internet for nutritional advice, but instead say, I had a Whipple, here are some good nutrition websites for Whipple patients. This will take work, but it won't be the exhaustive, resource-intense effort of primary nutrition research, which again, I think we're perhaps too heterogeneous for. And then include in there some very basic points like everyone should have a nutrition consult at the time of diagnosis and after surgery. Things like that. I do worry that, again, the root cause here is the cancer, and I think that it would be a very resource-intensive and perhaps futile endeavor to do a large amount of primary research across the heterogeneous nature of nutritional conditions in cholangiocarcinoma.
It's a great suggestion. Reid McNamara, Medical Oncology, Manchester. So this, it's so important, but I think what you could do as well is education for the institutions themselves. So for some institutions, we've no access to dietitians who specialize in biliary tract cancer. So only recently has that become possible where I work. So I think it needs to be included in guidelines so that it's seen by the institutions as a very big need. As Katie mentioned there, that everyone should have a nutritional input, post-surgery or whatever, which would never have happened in many institutions, and we don't even have access to dietitians. So I think having it included in guidelines where it becomes a priority for institutions to think of that role as being part of the whole multidisciplinary team that is needed, and not just dietitians who specialize in lots of different areas and don't ever maybe come to a HPB clinic. Thank you.
Thank you. That's a great comment that I think the community should act on, as it is true that not all patients have access to dietitians. Okay. Yes, microphone one.
Yes, as a patient, I concur with the person who just spoke to two people before me. The heterogeneity, the nature of our disease and the progression of it it's so varied. And I mean, there were times as a patient, in my treatment progression that basically, from a dietary standpoint, eat whatever I can keep down was the best advice that I could have received at that moment. But then, 2 months later, going through chemo or post-chemo, things change. So I feel like there was definitely a need for advice in my journey for some dietary advice. but if you could develop something for patients that is progressive in nature and does address the different aspects of the nature of our disease and the heterogeneity, that would be great. So just offering just different points of entrance and advice for the patients in their different levels of need, that would be great. I don't know, that's my take on it as a patient.
Thank you. Okay, are we ready to vote? I think we can vote on this recommendation and this wording, and then we'll try to refine another version if needed.
Nothing town. Textbook version of a kid going nowhere fast. And now I'm yelling, kiss my ass. It's gonna take a couple right hooks, a few left jabs for you to recognize you really ain't got it bad.
Okay, so I see that the wording has already been added, and including survivors is now present in the recommendation. I don't know what the idea of the working group chairs is in terms of a lot of discussion about heterogeneity. I don't know if it is worth it to keep the recommendation vague and just bring that comment in the action upon the recommendation if you wanted to include something there.
That's fine.
I think it's fine.
I'm happy with that.
So we
I
can
think
move on.
it's a real good first start.
Yeah. I think that we have actually skipped voting on the second recommendation, so we will just go back before we move to the next one. So the AT team, if you can bring up now recommendation number 2.
This one.
I think it doesn't need to have another
We are going to put
ground discussion, so we can just go straight to voting. Yes, Funda, actually, there is a question. Yes.
But I think they're wondering if we should change the statement so it can be included in the white paper or whatever.
So shall we go back to number 3 now and then finalize this one before we, okay. Yes, so should we say nutritional research and education for patients with early advanced cholangiocarcinoma and survivors is a priority with a specific focus on long-term nutritional needs and dietary recommendation?
I guess what I was suggesting was that primary nutritional research, specifically in cholangiocarcinoma, might be too broad and heterogeneous of an endeavor to justify the resources, to be more frank about it, but instead to tackle individual component parts such as post-Whipple, gallbladder, whatever the individual anatomic issues may be, and then consolidate expert guidelines from various other domains, whether it's pancreas cancer or the surgical societies, and develop an educational platform that people can turn to. I just worry that investing resource, I do take issue with the primary nutritional research. I think that will be very difficult.
I think what we want, I think we all agree with you, Katie. We just need to change the statement so that we are in agreement. Juan, did you have? Sorry.
I was just thinking on the lines of maybe anatomically appropriate. Katie, I don't know if that would fit. If we head off with anatomically appropriate nutritional research, I know this is still an issue around the primary research, but if we're focusing on the anatomy, then it makes it a little bit broader, so Whipples can include other patients as well.
I think it's education rather than research, right? Is what Katie is suggesting.
No, research and education, I think.
Okay. Oh, I see. Sorry, we're seeing the changes here.
If not, can you suggest some other wording? It currently reads now anatomically appropriate nutritional research. It still doesn't take us away from the primary research. Can you suggest other wording?
Guidance, guidelines, or cholangiocarcinoma specific guidance. I do think that primary research would be hard, but I agree with education as an alternate word.
So would you just say anatomically appropriate nutritional education in patients and take out the research piece? Is that right?
Which is fine. It takes it out of this priority completely. Given this, we need to separate what is a research priority, so put $1 million in to do research into this, versus something like education, which is more about practice, implementing changes. It is important, but we just need to be very clear that what we're trying to identify is there something here that warrants $1 million of research, for example? It might not be that, but just for an example.
Would the money then be spent on creating a platform? I think what a lot of people I'm hearing are saying is that we don't know who to turn to. And if the foundation is the place that we're going to turn to, if it could be a platform where we find this information, if that is not available to us in the place that we currently are, and it's bunched in groups of issues that we run into throughout the continuum of our journey. If it's early, then it may be the Whipple question. If it's later, as a survivor, it might be something else.
Okay, so I'm going to be a little bit provocative here. So what we're saying is, we need to provide good information, good education, but we don't need research. Is that correct? We don't need research? Are we really confident that we don't need research?
Go ahead, Melinda.
It's Christine Lafontaine from the Canadian Cholangiocarcinoma Collaborative. I would say that our group in general had a really hard time differentiating between what should be research and what should be education, and a lot of this falls into that psychosocial oncology, and so we really need the information about nutrition, but we want to also add that research aspect of assessing whether what and how we are presenting that information is effective. So I do think that there is a need for research around this, but maybe not that primary research.
I agree. I do think there's a need for research around this. One, because there's not a day that goes by that I don't get asked by a patient about what should I eat, what should I do. So I think we do need to invest in the research to create the guidelines and the resources that we can provide to the patients.
So do you feel like there is already enough research on SIBO, on these other issues, that we could gather that information and give guidelines, or do we need to invest in research so that we know what information we would give? What are your thoughts, Katie and Dr. Iyer? Anyone else?
I welcome obviously I'm not the expert in this myself, but I think that there are so many variables in terms of how the disease is responding and so many confounders in any question we'd ask that I'd want to harmonize our work with bigger groups and not use, we are a small, rare cancer, and many of these questions are actually have a much broader population, whether it's Whipple, gallbladder, SIBO, et cetera, that would be better served by research dollars from a much larger group. So I think we're prioritizing here, and also, so my concerns are the prioritization of rare resources and the feasibility of answering a question with all of the confounders, particularly the fact that status of the cancer, whether the cancer is progressing or not, is ultimately often the driver of how nutrition responds to a therapy. It's not the nutritional intervention, but the cancer.
Thank you, Rashna.
Yeah, no, I would agree, and I think it's also important to the point about finite resources for some of the initial kind of, research is the wrong word, but understanding to go into making sure we're not being duplicative or replicative in terms of a number of efforts that are happening across the space, albeit not specifically in cholangiocarcinoma, but that are still absolutely relevant to cancer patients as a whole, but of course, GI cancer patients, and then, drilling down all the way to cholangiocarcinoma, because the Society for Integrative Oncology has a lot of efforts in this space right now, and there's a lot of work that's already happening. And so I think the first step to really, if we are going to make research, because I fully agree with the education component, I think that really needs to be carved out and separate. But in terms of research, I'm not saying it should not be or should be, but if we are going to make research a priority, I think the first real important question is a real understanding of the work that's already happening across that space and how we can then become part of that and then take it to make it specific to our patient population.
Could I just, Stacey, could I just come in on all this? I think this is a really fascinating discussion. I'm really heartened that it's caused such a lively discussion, but I do feel in some ways we've come away from the patient and the patient's need. There is nothing, there's nowhere you can look that actually says when a patient has cholangiocarcinoma, whatever treatment they've had, whether it's surgery or systemic therapy or any other therapy, they need to be seen by a dietitian. They need nutritional advice. And I think that's the absolute baseline of what we were discussing. And you can look at what, pancreatic people probably have a lot of information, but I don't think we wanted, I may have this entirely wrong, but I don't think we wanted to go so firmly into the nitty-gritty. We just wanted to establish the fact that we need to have something that can be referred to say patients should have this advice. Is that too simplistic? I'm not sure.
Nilo, can someone get Nilo a microphone?
And meanwhile, maybe we can go to microphone 2, who has been waiting for a while.
Yeah.
George?
But from what I am hearing, there is a lot of hesitancy among the professionals here and surely among the patients to claim a great expertise in dietary treatments. We certainly, among ourselves, need some investigation, call it whatever word you want, to figure out what ought to be recommended under what circumstances. Maybe the research is at a level of literature rather than laboratory examination. What we really need is the expertise of dietitians, which do not seem to be among us in insufficient numbers. The research that's needed for us is to have consultations with dietitians who do in fact have the expertise to discover what is known, what is not known, and what the responses ought to be.
Yes, I think that no one is arguing that the referral to dietitian should be done. It's just that maybe discussing how much of this is a service implementation and how much is the need for additional research. And I mean that is, I think, very difficult to actually dissect down. So I think Nilo, you had a comment.
Yeah, I had a possible recommendation to edit, and that may be that it is a priority, but with deep collaboration required across the cancer community, the broader cancer community. And I think that addresses the feasibility issues. I mean, I think everyone in this room knows that we have, for 20 years, people have talked about the importance of nutrition and the worries that patients have around nutrition, whether they're making their cancer better or worse, whether or not they can help their family members not develop the same cancer. But the challenge is that these are extraordinarily difficult studies to do, even when they've been done by professionals that do have the expertise. And so I think that just allows us to say that we are going to intercalate with the broader cancer community, which is how there's actually no one tumor type that could do it by itself, not even breast cancer.
Just echoing that, maybe what we need is not so much research in the sense that the other working groups have been considering. It's not really laboratory stuff. Maybe what we need is some kind of a specialized task force among ourselves that would do the interaction with the other cancer groups and with dietitians to come up with a set of really very wide-ranging recommendations for different conditions that different cancer patients encounter.
Microphone 1. Oh.
Angela first.
Then Angela first, sorry.
Yes.
CV is very similar to
I don't know, can you hear me? Yes. My question is, have we answered the question that people with cholangiocarcinoma have a problem with nutrition and diet compared to the rest of us? Has that question been answered?
I would probably say yes, and the answer is yes. I don't know if everyone agrees, but Angela?
Okay, now. So I just wanted to say that I see this very similar to the comment we were having previously about the clinical trial design. It may not be an area where research and money investment is required in order to generate new data, but we definitely need to put the data we have in order with some recommendations, and we really don't know what to tell our patients, so I think recommendations around nutrition is definitely a priority and a huge unmet need. A task force working with dietitians, as it has been mentioned, I think is the key. And the reason why I think we are a little bit hesitant with research in nutrition is because at least we have tried in other cancers to do this type of research and generate new data, and it has been very difficult for that to change our practice.
Yeah, just to add a comment, I'd like to go back to Dr. Merrick Bernstam's comment. You know, we shouldn't be trying to reinvent the wheel. There are whole groups who are dealing with nutritional research. And I think what we should be doing is working with them and then building out anything that's specific to cholangiocarcinoma. But rather than trying to start from zero, is to work with established groups. It's going to need collaboration, and it probably also needs to link to anatomically appropriate groups. So then that kind of fits in with the Whipples and everything. Not sure how we put that into one brief statement. Maybe, can we try, Vindhya, can we try nutritional research in cholangiocarcinoma? Should build on the field of nutritional research, linking to anatomically appropriate groups. We haven't included education there, so maybe we put nutritional research and education. Apologies. And then we can get rid of all the rest. Okay, let's try that for the vote. So we can see the typing here. Sorry that you can't see that, but it should now be coming out as a push. We've not received the push yet. Thank you. Please vote now and submit.
Okay, better consensus than before, so we can now move on. And if we can bring up the recommendation number 2, for which the background has already been given, then we can make the poll.
Just as a quick reminder, this was talking about education program for cholangitis specifically initially, and now this is the second part that then goes on to managing other urgent conditions which happen in biliary tract cancer, including drains, I think. Thank you, Stacey.
So shall we go for voting?
Yep.
Yes. We can vote now.
Great. Thank you.
Yes, we can have questions first. Danilo?
Wondering if I would just wanted to offer a small edit about educating patients and providers. We have so many patients that come through our multidisciplinary clinics and as second opinions to us, where it's clear that even in the community, sometimes even at other centers, some of the complexities of managing drains are still a challenge. So I think it's more than patients that need that education.
And maybe if we can add also urgent conditions like, but not included to, biliary obstruction and drain malfunction. I'm thinking about clotting, for example, for patients who don't have stenting might be something that should be covered as well.
So develop a framework to educate patients and providers on managing other related urgent conditions. Sorry, Chiara, can you put the language to Vindia so she can?
Yes, so develop a framework to educate patients and providers on managing other related urgent conditions, like, but not limited to, biliary obstruction and drain malfunctions.
Like, but not limited to. Yep, perfect.
What is the other than?
Yes, you're absolutely.
Can we change like to including, please?
Better English.
Yeah, conditions including, yep. And you can keep the but not limited to.
Including
Is that
but
right?
not limited to.
Including but not limited to, yes. Thank you.
Okay, can we put that to the vote? Thank you.
So it reads, it'll come to the push, develop a framework to educate patients and providers on managing other related urgent conditions, including but not limited to biliary obstruction and, sorry, Juan and I are having the same problem, drain malfunctions.
I'm sorry, I don't know.
It's open to vote. Great, 98%, fantastic. Thank you. You can move on.
Yes, probably in the interest of time, we should move on as we have other two recommendations. Is the comment from microphone one related to this one?
It was related to that based on what
Yes, go ahead, Dan.
Dr. Valle had mentioned earlier. In terms of, this is Carmen, caretaker. So in terms of your comment, Dr. Valle, earlier about educating patients, I really took it to heart because when we're educating patients, we're really utilizing effective health education practices. So I want to make sure that when we think about it, I know you already changed the language, but when we talk about educating patients, that is put into consideration, especially when you mention testing knowledge, skills, attitudes, and ensuring that it's reflecting learning styles of the intended audience. So,
thank you, including good educational practice. I think that's a good comment. Thank you.
Thank you.
So, Stacy.
Okay, we are moving on to our third priority, which is complementary therapies. This is going to be a big one, so here we go. So what do we see as advocacy groups and what do patients tell us? We know that patients are using supplements and complementary therapies, also alternative therapies based on well-meaning advice and anecdotal information. Oncologists often do not ask questions about supplements and complementary therapies, and patients often do not feel comfortable disclosing this information. This bottom bullet is just a note that about 4% of adult patients participate in clinical trials. However, the data, the publications show that over 70% of cancer patients use some form of supplemental or complementary therapy. So just something to consider. So we had two research questions that we were thinking about. Are there any supplements or complementary therapies that have efficacy data? Are there correlations between supplements or complementary therapies and outcomes for patients? That's what we were looking at in the publications. So here are the publications that we looked at. I just want to give you a note. I'm going to give it at the beginning and at the end, that all the publications we looked at were on cell lines, small cohorts, case studies, and lacked specific data for cholangiocarcinoma, and all were lacking robust clinical trials. So there were 6 studies on herbs, and on CCA cell lines, ethanolic extracts, herbs and compounds, cannabis products. They showed various potential effects: inhibited cell viability, some inhibition of cell growth, induction of apoptosis, cell senescence, but all needed clinical trials. We then looked at cannabis in a palliative care and quality of life. There were 2 studies specific to cholangiocarcinoma. The first showed improved symptom management, improved quality of life. However, an ASCO study emphasized that the provider should have non-judgmental conversations with the patients, but that there was insufficient evidence to recommend cannabis as a symptom management. And then, again, we would just say, again, we need clinical trials. So there were some publications on Chinese medicine. This one was called Research Progress of Chinese Medicine Monomers. So they did induce apoptosis, inhibited cell proliferation, and suppressing metastasis, but again, need clinical trials. We then looked at vitamin C and curcumin or turmeric. The vitamin C was a study of multiple cancers in the setting of being used as an adjuvant to immunotherapy. They did suggest that it could help overcome resistance and epigenetic modulation and immune system enhancement. Then there were 2 studies on curcumin and turmeric, both saying, well, the first saying that it induced apoptosis, inhibiting cell proliferation, interfering with tumor growth pathways. It was a study on various cancers, but the problem was that it has poor bioavailability, it rapidly metabolized, and low absorption. The second is a combination of gemcitabine and curcumin. It was in mouse models in pancreatic and cholangiocarcinoma. They saw tumor reduction, tumor growth rate, reduced tumor size, reduced tumor growth rate, and LAT2 expression. So the things that we talked about after that were the different research questions that you would have to ask about all of these things. What's the active component? How much do you need to take? How often do you need to take it to have an anti-cancer effect? What are the side effects alone and in combination? Do they interact with standard therapies? Again, you would need clinical trials to get this information. So then there was a case study on hypothermia. This was done in 2024. The clinical outcomes reported that it improved local and overall treatment response, extended progression-free survival and overall survival rates, and enhanced quality of life metrics. CCA was the least studied of all the HPV tumor types, and we need clinical trials as well. Okay, just saying that everything that we looked at was on cell lines, small cohorts, case studies, and there was a lot of CCA data. Okay, so here's the recommendation. Our recommendation is to conduct an international survey to identify commonly used supplements and complementary therapies, with results guiding scientific studies on their benefits, risks, and widespread usage. So what we're suggesting is that all of the advocacy groups do a survey together globally, and hopefully we can identify maybe the top 2 or 3 complementary therapies or even supplements that are being used, and maybe this would give us a place to start to look more deeply into the research or to fund some research. Anyone from the working group want to?
Give the lights up, please.
Can I start talking? Oh. So one of the other things that we talked about was through the advocacy groups, if there were people who were part of one of the registries, that we could kind of look at what they've told us that might not be in their medical files about these complementary therapies and see if there's any correlation with their outcomes as well. Yeah. That might be something that we could also wrap into that.
Any thoughts or comments First step here again is a survey of all the patients. We feel like they're talking on the discussion board, not that we don't have discussion board anymore. They're talking on the social media, they're talking in all these different areas. They're asking about supplements, lots of anecdotal studies. We'd like to just get a survey about what is being used first. George?
I'm just wondering about expanding this to include complementary therapies that are not commonly used, but maybe ought to be because they could be helpful. There may be a handful of those, some of which have been studied, at least retrospectively, and maybe not yet in clinical trials.
Yeah, hopefully those will come up in the survey. If we're asking the patients to let us know, hopefully those would come up.
But the ones that they do not use.
Oh, the ones they have not used?
The ones they have not traditionally used. The one that may be on my list to attack next and that we looked at once before was aspirin.
Oh, I see. Yes.
Or CBM 588, a probiotic. Antihistamines for patients who are taking immune therapy.
Okay. Thank you, George. Sorry.
Really quick, between the comment down here and Stacy, just to clarify, when I first filled out the registry, I definitely did not use complementary supplements yet. So the survey, a new survey would definitely be necessary.
Yes, thank you.
Caitlin Conboy from Mayo Clinic. I think if you did this survey over time, every 5 years, you would find these trends, right? That's what it's going around on the internet. There's anecdotal evidence. It becomes popular. We could start a study on it, and 5 years later, when we had the results, there would be a whole new set of things people are using. I don't know if the trends that exist in the, driven by the internet and driven by rumor or anecdote are the best signals to chase if you wanted to say, we're going to build an agenda about investigating alternative therapies. I don't know that the most common is going to be the most likely to be effective. And I do think we might, got cut off. Okay. I do think we might want to address this the way we did with nutrition to consider whether we want to do the primary research or we want to be the clearinghouse for the wider research. Because I agree, most of these studies don't focus on cholangiocarcinoma, but they don't necessarily have to. Especially for symptom-managed things like cannabis, I think we should definitely leverage wider research that's done in other cancers and maybe take the same clearinghouse education focus.
Go back to 3, and then we'll come up to you, Dr. Iyer.
Hi, I'm Amelia Wagenknecht. I was an exercise physiologist with the Cancer Control Mind and Body Lab, and the research that I would specifically work on were exercise and nutrition interventions for patients undergoing chemotherapy, in particular GI cancer patients like cholangio. I would just like to add, we should survey the source of the supplements that the participants are taking, because supplements are not as thoroughly regulated and checked as drugs. So depending on where these supplements are being sourced from can be important, because a lot of them either will contain above or below the listed dosage of the specified compound, or just not even the compound at all. So it would be important to know where the supplements are coming from.
Yes, thank you, and that was something that we talked about as well. I think it's important to, this is a hard thing to do. We'll have Dr. Iyer, and then I'll have a comment. Go ahead, sorry.
Need and very, very important topic. Just wanted to make 2 small suggestions when doing the survey, to also ask whether to the point made earlier, are you on active chemotherapy or active therapy at the time that you're taking this? Because I suspect with some of the patients that they're not taking it while they're on chemotherapy, but they are later on. So that could be important as well to know.
Yes.
And if you hadn't already thought of it, including some sort of holistic expert or complementary integrative oncology expert to comment and, you know, especially on dosing curcumin 1,000, 2,000, that would be
Yes.
very helpful. Thank you.
Yes, thank you. Go ahead.
Can you hear me? Yeah. Alicia Conway from Manchester, UK. I just wonder, echoing some of the other comments, that there'll always be complementary therapies, whether the evidence is there or not, and perhaps trying to elicit the reasons behind using the therapies. Is it symptom control? Is it general health? Is it the anti-tumor effect that they're hoping for? Because that shows us the gaps in where we haven't got the therapies or we haven't got the right symptom control measures for the patients. But I agree that you could go down the rabbit hole of trying to build the evidence, and a new complementary therapy will exist in several years' time.
Thank you. That is noted. I'm not sure we have time for one more comment because we don't have quite enough time, and we've got one more to go. So if we can move to the recommendation, if that's all right. Thank you. And again, this is our starting point. These are such rich discussions and things that we can collaborate.
Thank you. The vote's arrived. Please vote.
Out of the ashes, I'm burning like a fire. You can save your apologies. You're nothing but a liar. I've got shame.
Okay, we did not reach consensus.
Of the 1 in 4 people who disagreed, can somebody suggest any alternative wording that would get this over the line? We can try once more. Is anyone willing to give it a bash?
Anyone willing to share why they disagreed?
Christine.
Right, so I think we kind of parsed out 2 different issues here. We want to conduct an international survey to identify commonly used supplements and complementary therapies so that we can just have an understanding of what people are doing outside of traditional medicine. And that can identify the gaps, that can identify those types of things. And then that can also maybe help guide our education in just being able to do a little bit of the background research to say, these are the cell lines that have shown something, but really trying to educate patients in that, like clinical trials need to be done, and this is why clinical trials are important. And then separate from that, truly identifying the complementary therapies that might be actually useful. I think there are 2 different issues there.
Okay, let's hear the other comments first. Number 3.
Hi, yeah, I'm actually a patient, and I want to say I agree with this, and the reason why is I've gone through all the traditional therapies. I've done chemotherapy, I've done radiation, but my body's at the point now that if I get another reoccurrence, I'm not going to be able to handle the chemotherapy. So I was a registered nurse for 40 years, so I would like some studies done that say, we have found this alternative therapy works, or that alternative therapy works, because if you get on the internet now, everything cures cancer. Now it's baking soda and lemon juice, it's soursop, it's ivermectin and fenbid, whatever. And I would like some studies on supplements that we can go to and say, okay, these are proven to work. Because I don't think I can take chemotherapy again. I can't have surgery again. So for me, I would like something else, just in case.
Yeah, number 3, you 2? 2. Sorry, I can't see.
Hi, Jennifer Wild. I'm an RN at UCSF. I actually voted agree. However, I waited until there were like 5 seconds left to press agree. And the issue that I had with the wording was that the two different parts of this statement, conducting a survey and guiding scientific studies, it's unclear to me whether we're saying that we're conducting a survey and appropriating funding to potentially guide the studies, or if the survey is potentially going to guide studies with future funding. Again, just remembering that the whole point of the voting is to prioritize our research money, and so I think that focusing right now just on the survey is the main first step, and maybe the wording could be changed to say, with results guiding future scientific studies. And that way, if there is still budget for it, we include it in this current move, or it could be something that we table for later on if funding does not permit.
It's like Matt.
Number one, Matt Reedy, patient. I disagree. I think it's a slippery slope to have to go down this route. I manage one of the social media Facebook groups that tries to be more scientific than anything else and talk about targeted therapies and things. And the amount of BS online is overwhelming. I'm all for people finding alternative therapies and things that make them feel better, but and that's great, but trying to prove it scientifically, like somebody else had said before, it's like the nutrition. I don't think there's anything unique about cholangiocarcinoma and supplements and alternative therapies and things that we should be necessarily spending time on as a community, other than leveraging what other people have already been doing or have already done, and kind of putting a rubber stamp of the foundation on some of these things, you know, without going through the science to prove or disprove. I just think the cost is not worth it.
Thank you, Matt.
I think we have an answer here from the
Can we get a microphone to Rashna? Or Rashna, you can go
Katie.
back to one right there, right behind you. There you go.
Katie's got a microphone already.
Oh, I'm sorry. Katie? Oh, no.
No, Katie, me. Sorry. Katie Glenn. I think that there is a need specifically for cholangiocarcinoma. You know, like, for example, when there's a bile stricture, you shouldn't be giving a patient, which I did for my dad, curcumin. That causes more issues than any benefit. But when we're out here without medical degrees trying to navigate this on our own, no other cancer could have told me that.
But I think the key point here is, does curcumin have a benefit? And we haven't answered that question yet.
Yes, thank you, Katie. Rashna and then Melinda.
Sorry.
So
I said agree. I guess the nuance that maybe was just being alluded to that could clarify some of this is, my interpretation of how this recommendation was written is, let's do a landscape survey to really understand, and then things are going, I mean, absolutely we should include what everybody is doing and have, you know, open-ended questions written. I mean, good luck writing this survey. This seems hard. But the idea of, you know, having things boil to the top, right? So if 50% of people are saying, yes, I'm using curcumin, 50% of the people are saying, I'm doing hyperthermia, I think that helps drive the next step to determine what the research priorities are. So that was my interpretation of this recommendation, and that is why I think it's important, is because, you know, I completely agree with you, Matt, wherever you went, that, you know, it is really important to have that scientific data behind anything that the foundation is going to put their rubber stamp on. But I don't even know where, because to your point, Stacy, this is such a huge space. Like, how do you even know where to start? And so that was my interpretation of the survey, and I think maybe there's a better way to word it so we can say to guide, you know, priorities for the next steps of research or something like that.
So can we just amend the word, conduct an international
Rashna.
landscape survey? If you can add that word in, thank you. And then it's with results to prioritize future scientific studies. and take out the commonly used. To identify used supplements, just take out the commonly. Thank you. Sorry, we're doing this live. Thank you.
Go ahead, Melinda.
Yeah, no worries. I think that landscape survey is so important, but I would also add, like, the financial toxicity that goes into it. I've seen patients mortgage their homes for alternative therapies, and none of this stuff is covered by insurance, right? So I would love to know the financial aspect that goes behind it. And plus, to emphasize too, that just because it's alternative doesn't necessarily mean it's not toxic.
Thank you,
Yes,
Melinda.
I think we have space, time for just another question and comment before we vote again. So number 3.
Fred, go ahead.
Yeah, Fred Neubauer, patient. I feel strongly like Matt Reedy that you're kind of going down a rabbit hole. I know particularly the benefits of vitamin C. You know, I'm old enough to remember Linus Pauling and all the work he did on vitamin C, and it was all infusion-based high dosage, and a lot of the, you know, over-the-counter stuff doesn't even get absorbed by the body. So I like to see a more technical approach, and if you do a survey, maybe ask how these supplements are applied. If they don't get in a bloodstream, they don't work, and gets to Melinda's point on economics. So,
Thank you, Fred. Appreciate that. We need to move to the next vote. So you should get another push. You can see the changed language there. We hope that addresses some of the concerns.
It's not appeared. Okay, it's been updated. Please vote now.
Here we go.
Great, thank
Nice.
you.
Thank you.
We'll move to Helen's
can
next
move
priority.
To the next recommendation.
Just to say, we're probably going to overrun this session by 5-10 minutes. We can fit that as we can then just squeeze in a little bit of the lunch. So.
Thank you, Juan, but I won't keep everyone from their lunch for too long. I'm going to talk about the last thing that we decided to put forward. As Stacey said earlier on, we had a lot of priorities. We could only pick 4 for today, and the clinical nurse specialist was one of them. So first of all, I'm just going to explain what I mean by a clinical nurse specialist. And this is something that we do have in the UK. The clinical nurse specialist is a qualified nurse, highly experienced in a particular area, for example, hepatobiliary cancers, who is uniquely placed to support patients such as those with cholangiocarcinoma. I don't have to tell this audience that being diagnosed with cholangiocarcinoma is deeply upsetting, it's frightening, it's confusing for the patients and their loved ones, and that's putting it mildly. So it can be difficult to make sense of everything, and an enormous challenge to have to make decisions about treatment and to navigate through an increasingly complex health service to find the right care. So clinical nurse specialists are an important point of communication from the start, offering advice and help in many areas. For example, supporting through the shock of diagnosis, helping with decision-making, giving reassurance, answering queries, and advising on services that might be available. So in short, the clinical nurse specialist can offer holistic expert care which crosses care boundaries, emotional, practical and physical support throughout the cancer journey, and this is on a one-to-one basis. When it works, this is an ideal situation. But we don't have enough clinical nurse specialists in the UK, where under our National Health Service, it often comes down to finances. There are very few nurses of this type in Europe. In other countries, there is similar care, but they're known by different names. And I believe in the US, you have hepatobiliary nurses, and they are medically trained, and also patient navigators who are not medically trained. So what do we know about these nurses? What do our patients tell us? There have been a number of reports and published papers supporting the role of the clinical nurse specialist as being beneficial to cancer patients. One report from Cancer 52, the Alliance of Rare and Less Common Cancer Charities in the UK, includes a comment from Matt, a young man in his 30s with cholangiocarcinoma, and he said, "To my clinical nurse specialist, I'm a person, not a cancer. She really understands the complexity of cholangiocarcinoma, answers all my questions, checks and follows up on treatment options, and gives me reassurance. It's like having a virtual hand on your shoulder all the time, giving me confidence." So it seems that patients greatly benefit, but what about the hospitals? Can we find any evidence that clinical nurse specialists are actually very cost effective, and by showing that, encourage the appointment of more? As a group, we set out to explore what research there currently is into the clinical nurse specialist. So we found a number of very positive papers, including the following examples. A review from the Canadian Oncology Journal noting that the clinical nurse specialists significantly contribute to improved patient outcomes, and firmly establishing that they are a valuable MDT member in enhancing cancer care services. And a review in the Brazilian Journal of Nursing, which found clinical outcomes demonstrated positive findings for patients with clinical nurse specialist support, including, importantly, decreased distress, anxiety, and depression, improved control and management of symptoms, improved physical condition, improved quality and continuity of care, improved quality of life, and reduced time to starting treatment. So, following on from the literature review, the group would strongly suggest that the case for clinical nurse specialists in the care of those with cholangiocarcinoma is made. But what we didn't find, what is missing, is economic evaluation. So the question then is, oh sorry, I've gone too far. So the question then is, can research be generated to show the cost effectiveness of implementing clinical nurse specialists into various healthcare systems around the world via, for example, reduced hospitalization, reduced attendance to the emergency department, reduced length of stay in hospital, improved quality of life, and improved survival. And this is our recommendation. That research is warranted to evaluate the cost effectiveness of the clinical nurse specialist role in the management of patients with cholangiocarcinoma.
Okay, thank you. Can we bring the poll up? Any quick comments before we vote? Yes, number 2.
Jennifer Wild, UCSF RN again. I think that in the United States, there are very few CNSs actually. CNSs are outnumbered to NPs in terms of the advanced practice nursing spectrum by, I think it's like 4 to 1. And CNSs, there are fewer than 100,000 in the United States right now, whereas for registered nurses, which is not an advanced degree, there are over 4 million. And a lot of the roles that you described on your slides that are performed by CNSs, in the United States, a CNS degree is not required for some of those tasks and roles. And so I think in the United States, you might struggle with the wording of this research recommendation to have a large enough body of research because so much of what you are focusing on is currently performed by a role in the United States that we call nurse navigator, which is not a CNS. They're registered nurses like myself. And so I don't disagree with the mission of the recommendation. I just think that we might need to retool the wording in order to have a larger data and sample size to prove the effectiveness of nurses who perform these types of tasks.
What would you replace clinical nurse specialist with in the recommendation?
Oh my goodness. I think if we're going to do international research, you probably need to include both terminologies, clinical nurse specialist and or nurse navigator.
Or should we call it like an expert nurse role or something like that, something a little bit more generic?
Well, I also think that if you're going to do like a systematic literature review, for example, having those two different keywords is important. Nurse navigator is probably the predominant terminology in the United States.
Thank you.
I was going to kind of reiterate some of the stuff that she was saying, plus the majority of patients, I'm Tanya, I'm a patient, and I'm also a nurse. The majority of patients may get some care at a tertiary care center where there may have some availability of a CNS, but the majority of patients then go back to their home base and get all of their care managed there with just occasional conversations with that tertiary care center. So they do not have access to CNSs. But I also, from a financial standpoint, I'm wondering if you can kind of involve insurance companies, because if we have some kind of a specialist role to manage symptoms, prevent rehospitalization or initial hospitalization, it's cheaper to employ one nurse at every institution than to pay for every hospitalization that may be repeated.
Thank you. Yes, Katie?
Katie?
Katie Kelly, UCSF. I fully echo both of those comments, and I will emphasize and underscore that having a dedicated nurse with expertise in biliary tract cancers such as Jen Wild makes an enormous difference. So I highly applaud the goal of this, the spirit of this recommendation. I think in implementation, it might be helpful to think through a very specific question. For example, developing an outpatient management of early onset cholangitis, for example. You could imagine intercepting hospitalizations and crashing into an ER with a nurse who's closely integrated with a hepatobiliary stent program, outpatient antibiotics, things like that, and then conducting a survey in a finite number of centers to look at hospitalizations prevented, for example, as your metric, rather than a more global question about cost effectiveness. So it will require very specific scenarios to be studied.
Yeah, I'm not sure how we would reword that, and I think what we as a group came to understand is that there is no doubt the clinical nurse specialist, if a patient is appointed their own clinical nurse specialist, that they can contact, it's their first point of contact with all sorts of questions. And ideally, as you're saying, if they are, particularly if they're stented, you know, they can say, oh, I'm not feeling good, what should I do? They can speak to their clinical nurse specialist immediately. But I think what we were working out is they can be expensive. To supply this service can be expensive. How can we justify it for the hospitals?
I take on board Katie's point, but at the same time, I think that if you want to go in countries where you don't have any patient navigator or CNS and say, you know, there will be an advantage in reducing the cost for the health system if you just shift those costs for hiring this new figure, whatever we want to call it, probably limiting to the one specific activity might not make the point.
Angela, and then Milland. So, sorry, Angela Lamarca from Spain. So I wanted to comment a couple of things. One of them is I don't think we should really use a synonym CNS as a patient navigator, because the risk there is that it's much cheaper to appoint someone who may be a patient navigator who doesn't necessarily have the nursing knowledge. And I think that that's something that may be starting to happen, that people are appointing patient navigators, they tick that box, and they don't really have access to our CNS, which I think is where really the benefit relies. And the second point, speaking from a country where CNSs do not exist and where I really, really strongly believe that we need them, having this cost-effectiveness research will be really important. If I can show to my hospital that having a CNS and appointing a CNS is avoiding a patient going to the emergency department, is avoiding admissions, I think that could be very, very valuable. But I will definitely separate CNS from patient navigation.
Microphone 1.
Thank you. You know, I do agree with Angela that these terms are confusing. So I'm in charge of the GI Navigator, Nurse Navigator program in our center. And I would say, I think this is an ideal world, wonderful. They complain that they're not quite sure what their role is. Are they going to provide concierge services to these patients? Are they going to help them make appointments? Are they going to try to get their PTCs done sooner? Or are they going to be an educator? So we have a navigator, but that's not what you describe is not what they do. My nurse is here and she does a wonderful job educating, but not to the level that you describe, right, from the diagnosis. So I think this role is, I think it's required. I'm just not sure how we're going to do it because it's very comprehensive. And at least in our navigator program, we find it difficult because the physicians, their expectations for the navigator are not really met by the navigator themselves because we expect them to do too much.
Benjamin?
I'm Benjamin from Scotland. I'm a patient. I'm very, very, very biased. I've had a series of 4 wonderful CNSs who've been complete lifesavers. I also know people who are treated at hospitals without sort of proper CNS provision. I think the biggest thing about having a cholangiocarcinoma diagnosis is the trauma and the mental health impact. The CNSs that I've worked with have been curators, advocates at MDT meetings. They curate all the test results, and they're absolutely phenomenal. You will see your surgeon oncologist who might be limited to sort of 20 or 30 minutes, and they're great, and they'll sort of call you up on a Friday night and sort of. But the CNS is always there. I mean, mine are virtually on speed dial, and it's a role that I think everyone I know who has had access to a CNS, they couldn't do without. And those that do not really regret and are really envious of those of us who have had really amazing support from the CNS. So if it's not something that is available as much in Europe or the US, I would thoroughly recommend it, and it needs more research.
Thank you. I think we have to move on voting and maybe.
Very quick, the new wording. So I think maybe maybe it's not cost effectiveness. Maybe we're just not at that stage yet. Maybe the research that is warranted is to evaluate the current landscape of nurse specialists, nurse navigators in the management of patients with cholangiocarcinoma, which then could inform cost effectiveness studies to further broaden their scope of practice and their implementation across healthcare centers or something like that. But I'm saying that I think the research is needed to understand the current landscape internationally of nurse specialist and adjacent nurse roles.
I might disagree with that because I think it's really important here to understand if it is worthy to pay extra money for this role rather than just having a survey of what is the different nursing roles in different countries. But
not all the roles.
Open to comments.
The roles like this, because I think CNS in the United States it's just not a thing. And to be honest with you, it's probably going to be gone pretty soon with the DMP requirement for nurse practitioner. And so I think that maybe this cost effectiveness study would probably be a very specific focus, only in the UK perhaps, maybe a couple other countries. It would be probably a very small study, I'm saying, if you keep the current wording.
So you would add an adjacent after clinical nurse specialist, what would you add there?
Clinical nurse specialist and similar roles. And then your work group could determine what qualifies as those similar roles. But maybe just expanding the wording to be inclusive of the analogous roles that have different names in other countries.
Okay, so let's assume that we're going to add and similar roles after clinical nurse specialist. I think
Similar, equivalent, something like that. Yeah.
Move to the vote.
Thank you, Jen.
Should tumble and fall, or the mountain should crumble to the sea. I won't cry, no I won't shed a tear, just as long as you stand by me. And darling, stand by me.
Okay, so we'll work a little bit on the wording, but we have a consensus, so we can now conclude this session. Thank you very much, Stacey and Ellen and all the group for the incredible effort you've put into this work.